But in general, what we're trying to do here, EHRs have no secret that problem lists are challenging. And that's largely because most EHRs have sort of undertooled their problem lists, and it makes it difficult for providers to use the problem list effectively within the encounter. So we've created an application that brings some of those keys to VBC success and also some clinical tools that will help the provider make the problem list a more useful clinical tool and not a pain point in their encounter, but something that can actually help them better take care of patients and better act on conditions of interest. So you can see our problem list here on the left side. We've organized it not alphabetically or chronologically or just a random sort, but the way a doc thinks about the patient. We organize those problem lists into clinical categories, generally aligned with common clinical specialties. Patient safety issues, advanced directives go right to the top. This is an easier way for the provider to get a quick view of the patient's clinical story, understand everything that's going on, and orient their encounter and patient care accordingly. You can see we clearly call out those conditions that are HCCs with these flags. I'll show you what these look like in a minute, but these actually indicate the status of that HCC, whether it's been coded in the calendar year. Orange is the action color, meaning it hasn't been coded yet this year. But if this problem list is anything like most of the problem lists we see out in the wild, it's probably out of date. So we have a cleanup tool that can identify conditions that should likely be removed from that problem list. This doesn't happen today because EHRs don't really have tools to assist with this. So it's a manual effort, and the provider has to take the time, the mental energy to clean up that list with no assistance. And so it frankly doesn't happen. So we're trying to help the provider here, identifying conditions that should be removed based on the onset date. And if that condition is acute, likely should be removed from the list because it's no longer active. We also find duplicate problems and even similar conditions where it's not an exact duplicate, but very similar. We can alert the provider to those redundancies. Now, in this case, I'd call your attention to the acute MI from 2023. That should no longer be coded as an acute MI. Frankly, if you try to recode it for the current encounter here in 2025 as an acute MI, you're inviting an audit. We'll talk a bit more about that later. So we should really be removing that from the problem list. But rather than the provider having to spend a bunch of time and mental energy going through this list, they can review our cleanup suggestions and with a click, remove those unnecessary problems and get them off the list. Now, we can also assist with the flip side. And this is really important when it comes to risk adjustment, where we can look through the patient's chart for chronic conditions and HCCs that the provider might not have had on the radar because they were not documented on that patient's problem list.